Well, welcome on a non-Zambian night to be here. And I'm sure that our lecturer is going to warm you up with all of his information that he's going to share with you about the work he does in Zambia. So I'm Peter Kern, Director of the Global Public Health Program. And this is our lecture series, the Global Public Health Lecture Series, sponsored by the External Advisory Committee, Global Public Health, the Institute for Health and Humanities, and with a grant from MCAT to help us videotape these so we can share them with people who can't be here tonight. So I want to thank you all for coming and remind you please to sign in either the sheet for students or the sheet for community or non-student members, which gets you enrolled in the drawing that's coming up at the end of the lecture series. So tonight I'm happy to introduce Phil Seidenberg. He's going to speak about the work he's done in Zambia with implementing a program that focused on prevention of mother-to-child transmission of HIV and also on early infant diagnosis. He spent 6 years in Zambia conducting research focused on child survival, community case management of childhood diseases, technology and EID, and trauma. He's a co-principal investigator in the Pneumonia Research for Child Health Study. That's a multi-country study, 7 countries, 9 sites, that looks at causes of severe pneumonia in children under 5 years of age. The largest study of such topic ever conducted. He's currently teaching at the University of New Mexico, where he focuses on clinical care and research in the Emergency Department Observation Unit. And his research on Zambia is ongoing. So I'd just like to make a special note that Phil was able to come here on his own expense, and I really think that we all should appreciate that because it's wonderful that he can come to Montana and share with us the work that he's done in Zambia all the way from, I presume, much warmer New Mexico. Please join me in welcoming Phil Seidenberg.
Thanks. I hate skiing as well, so the fact that it's snowing so much and tomorrow is not going to be a great day on a mountain somewhere in the near neighborhood. So thank you for that introduction, and I'm excited to be here. Sorry, we had some technical difficulties, so I'll make sure it works. Yeah. So as Peter mentioned, I have ongoing work in Zambia and other parts of Africa, but for 6 years I lived in Zambia after finishing my residency and working a little bit in Austin, Texas. By training, I'm an emergency medicine physician. In the middle of medical school, though, I got a little bit involved with HIV research in Zimbabwe and was dragged to Africa for the first time, where I kind of fell in love with the place and kept going with some thinking about it and involvement in research studies. But most of my work was through Boston University School of Public Health and the Center for Global Health and Development. I was the country director for all of our studies on the ground there in Lusaka, Zambia, but they were done throughout Zambia. We had about 600 employees total. Most of our funding was coming from U.S. government sources and Gates Foundation eventually when we started getting a little bit larger grants. I also was a lecturer in the School of Medicine in Zambia, and my first day there, the head of the hospital kind of asked me, do you know anything about critical care? And I said, well, I'm an ER doc. I know a little bit about it. It's like, good. Can you run our critical care department? And so in the mornings, I used to go and help run the ICU. And in the afternoons, I had my paying job, which was conducting research throughout the country. So it was a great experience. As part of that, I was involved with a bunch of technical working groups at the Ministry of Health level, where I sat through and helped think through some of the bigger health challenges in the country of Zambia by the way of what we were doing in the country. Yeah. As Peter also mentioned, here are some of the areas of research that I'm doing. I purposely did this because I want to be invited back, but I've left off the kind of the more exciting one, which is looking at the causes of pneumonia in under 5 children. And in fact, our big study, the 7-country thing that's been ongoing, and we've been writing it up and had 40 to 50 publications since then. The main article is coming out in The Lancet sometime in the next 2 months. So we haven't gotten an exact date, but they're going through the last edit. So this kind of has looked at what's causing pneumonia in kids during the time of HIV disease, during the time of expanded vaccination coverage around the world. So this is largest study that's ever done, 5,000 children enrolled in it, and the goal of the study is to look for developing treatment algorithms or further vaccine development based on what's causing kids pneumonia in kids these days. So that's probably the most I'm going to talk about that. But some of the other things, as Peter mentioned, are on there, including, because I'm an ER doc, we set up a trauma registry there as well. But for the most part, the work that I did and the work that I continue to do in Africa is focused on child survival, and it's anything that's looking at causes of illness, causes of mortality in kids. What can we do about it? Are there any novel approaches towards seeing if we can improve survival in children? Always people ask me what brought me to Zambia. Were these guys did. So my wife, who's South African, dragged me back to the continent because she was missing being close to home, and we wanted to raise our kids there, who are a lot bigger than that now. But that was one of the main drivers. So you never know where life is going to take you, and this got me thinking a little bit more about what a career in Africa would be like. But those are the people that really drove me to spend so much time in Africa. All right, so again, what I would like to focus on a little bit is under 5 child health here, and I'll get more specific to Zambia, but first I thought I'd throw out a few statistics and ideas around this. If you look at the improvements in under 5 survival around the world, there have been remarkable ones in the last 30 to 40 years. Ever since we set these Millennium Development Goals, or is anybody familiar with the Millennium Development Goals? And now something called the Sustainable Development Goals, which were through the UN, ideas of can we actually make these types of improvements in health. So it wasn't those themselves, but it allowed some concerted efforts towards improving child health. But there's been some remarkable improvements. But again, as you can see, still in 2017, if you're a child born around the world, you've got a 1 in 26 chance of dying, which equates to about over 5 million deaths. And a large proportion of those are in sub-Saharan Africa. As you can also see, out of the 5.5 million, about half of those die within the first month of life. If you look at the top 5 causes, those are they. So not surprisingly, preterm birth complications. So safe delivery, safe care around delivery is really important. Pneumonia makes it up to the second on that, so very high on that. Birth asphyxia, back again to the deaths that occur in the first month of life, and then diarrheal diseases and malaria. Yeah. Yes?
Have you found any significant differences among sub-Saharan African countries? Positive and negative?
Absolutely. So again, absolutely. So in terms of the causes, for instance, of somewhere where I'm a little bit more of an expert, pneumonia, if you look at what the causes of pneumonia in kids are in, say, South Africa versus Zambia versus West Africa versus Kenya, there certainly are differences. But we do know, and then malaria has obviously been better eradicated in certain parts of sub-Saharan Africa than others. But typically, if you look at, for instance, Malawi and Zambia or Zimbabwe, those same causes still make it up to the top of the list with some variation. Yeah, absolutely. Good question. Yeah. This kind of gives you a graphic presentation of what that looks like. So you can see from 1990 all the way through 2017. And this gives you the number of deaths per 1,000, and that's how we kind of track under 5 mortality. With maternal mortality, we track it in terms of 100,000 births, but with kids, we do it in terms of 1,000 live births. That last line on there is the neonatal mortality. So you see as mortality has come down for under 5, a larger proportion of those kids now that are in that under 5 group are being represented by kids actually under the age of 1 month of life. And even if you break that down, it's the first 7 days of life, which really are the most dangerous period of time for child survival. This is maybe hard to read from the back, but again, in terms of color, if you look at the highest under 5 mortality versus the lowest, there's where you see where Africa just kind of glaringly stares at you. There's a couple different spots in South Asia as well, and a few kind of represented in parts of South America. But again, it's a disproportionate number or risk of dying if you're under 5 in Africa. Yeah. And then if you look at the causes of death in these age groups, this kind of will break it down a little bit further. So, and these are just terms that are used in child survival. Neonatal period is within the first month, infant is within the first year of life, and then child is 1 to 5. Is anybody familiar with the global burden of disease study and Chris Murray and his work at Harvard? So these are statisticians, epidemiologists that have basically tried to look at what's causing people to die. And the most recent one they published was in 2012. I wish to say that I understood their methodology. It is crazy when you read these articles on how they actually come up with these statistics. But again, there's death registries, there's all sorts of research that's done in areas, and they try to take those data and they extrapolate that to get an idea of what's causing death. Country registries is a big source of this. They actually approached us for our trauma data because they had none in Southern Africa. So they extrapolate something that happens in Zambia to nearby countries to get an idea of this. But in this area, it just shows you what some of these deaths are. And again, lower respiratory tract infections, a big area of my research, is really high on that. We don't know if that's pneumonia or not because we're a little bit biased towards defining pneumonia as something you see on a chest x-ray, but we know that these are respiratory type illnesses on it. Sepsis in the neonatal period is just an undefined infection, and there may never be, understand exactly what's causing that, but that's just overwhelming infection. Yeah. I threw on injuries and HIV on there and the older ones just to give an idea of that, but injuries certainly start playing a really much bigger part. And if you look at the 5 to 14 age category, injuries are in the top 3 or 4 causes of death, and then certainly throughout early adulthood. Yeah. So here's Zambia. So if those of you that aren't very familiar with it, it's a landlocked country. It's in southern Africa. It's got a population of around 16 million now. It's fairly urban, actually, so 35% actually live in urban areas, which is a growing trend in parts of sub-Saharan Africa as well. Still, it's a pretty high birth rate. Per capita GDP, you can see on there, 3,000, which is a little skewed because about, as you can see, 40% of Zambians still survive on less than $2 a day, and 60% of them are considered in a state of poverty. On it. Life expectancy is starting to come up a little bit as the country has kind of faced the HIV epidemic successfully and somewhat successfully, although you still see an HIV prevalence of 14%. And again, maternal mortality, which is a very hard statistic to actually estimate, but is around 398 for 100,000 life births. It has a rainy season, it has geographic variation. It has 77 different larger Bantu ethnic cultural groups in it with varied languages, and the administrative language of the country is English. Yeah. Copper probably drives most of their economy. Yeah. Still today. This gives you an idea a little bit of, if you look at some health statistics between Zambia and the United States. I always like to show this to my residents when I get asked to give global health lectures. But again, if I only use physicians, but you can use any healthcare provider. In fact, the discrepancies or the shortage of healthcare providers in Zambia and places like Zambia is glaring. But you can see 1 per 416 is the number of physicians in the United States, 1 for every 23,000 Zambians on it. The life expectancy differences. If you see the maternal mortality differences, and again, 21 in the United States. So so our number actually is kind of, depending on where you are, is going up a little bit, which we're knowing maternal health is actually becoming, in parts of the United States and different ethnic groups, is actually becoming more dangerous on it. But then you see the HIV prevalence. So Zambia is probably the 2nd or 3rd highest HIV prevalence in the world. I think Swaziland's is a little bit more. And then there you have the under 5 mortality. Healthcare costs, obviously, United States spends a lot of money on healthcare, and Zambia is a lot less than that. This is something a little bit more for anyone in the medical profession. So I've given a few lectures on surviving sepsis in a place like Zambia when I worked there versus sepsis in the United States. And I always like to show my residents and people the differences between what's available in the emergency department when I worked in Lusaka versus where I work now. And UTH stands for the University Teaching Hospital, but as you can see, it was a huge city, 1,400 beds. I don't know if there are any, maybe Bellevue in New York has 1,400 beds, but there really aren't any hospitals in North America that are that size, with very few ICU beds. So as much as they wanted me to run the ICU, there wasn't much to do in the ICU because there was only 12 beds on it. But again, in my resuscitation bay at University of New Mexico, I've got techs, I've got x-ray techs, I've got people that are helping me. Absolutely none of that existed in Zambia, and in that emergency department there often was, the best way to equate it is the mass casualty of sepsis. So it was just a bunch of very, very sick patients coming in. Cool. A few pictures from the hospital. Yeah. And here are some pediatric indicators. So again, a little bit more focus of my work. So you can see the neonatal, you can see some of the numbers. My apologies, that child should have been corrected. It's about 60 now, deaths per 100,000. And again, prevalence of ARI. So if you go out and ask people throughout Zambia, and this is how we actually find this, and I'll mention that in a future slide, but about 4% of kids under 5 when surveyed or when moms are surveyed actually had evidence of upper respiratory tract infections in the 2 weeks prior, and 16% of diarrheal diseases. So these are real things. I mean, they're definitely causing illness and death. Malnutrition indicators, so we use something called, stunning looks at height in particular, but that WAZ is weight for age. So we know that certain weights should be at certain ages, so you can determine how far off someone's growth curve they are by calculating that. There's other ways to look at malnutrition, either acutely or chronically, that we'll record in many of our studies and work. But as you can see, vaccination coverage is pretty good. So, OPV stands for the oral polio, so almost all kids are getting vaccinated. And in fact, they've introduced 3 main vaccines in the last 20 years that are going to have and have had and will have remarkable effects on child survival. So the Haemophilus influenza, so the HIV vaccine arrived in 2003, and that's universal now. And in the middle of our pneumonia study, they introduced pneumococcal vaccinations. And so we have those in the United States. And so pneumococcal disease, actually, our pneumonia study can kind of look at pre-introduction and then surveillance then afterwards, because again, it won't affect that study as much, but we can see the types of pneumococcal strep pneumo that are causing illnesses amongst the pneumonia populations there. But that got introduced in 2013, and then rotavirus around the same time. So and there's been some great studies that have shown in South Africa and Malawi that rotavirus introduction as a vaccine has made a remarkable improvement in child health. So where do some of these data come from when we look at this? Well, one is from something called the Demographic Health Survey, and many countries will actually do this. And that's where, and this is actually a company, of all things, in North Carolina that grew out a research triangle with public-private partnerships with support from the United States government, the CDC, and also governments in Zambia and other places around the world, that they'll have them come in every 5 years and really go out and surveil across the country. So, and I think in the most recent one of 2013 and 2014, they looked at over 7,000 households, and they sample like you would expect. They would do urban sampling differently than rural sampling, and they'll get a real mixture of it. And it's a pretty good science, in fact, how they do this. And outside of asking questions, then they will test for malaria and they'll test for HIV. And so that's where some of the baseline data on health amongst both children and adults comes from, is surveys like this. This is where all the information on a child actually is kept in Zambia, so no electronic health records. So this is the under 5 card. And so everything from mom's antenatal care to birth history is kept on here. And it's a little fuzzy for you, but in a place like Zambia, it's really important to have prevention of mother-to-child transmission of HIV. So they'll put that information on. So what mom's HIV status is, what mom received for prevention of transmission to her child, and what the child's testing status is. And then there'll be some information around local diseases. And this will be also printed in multiple different languages, so it's not just printed in English. Yeah. And then on the second page, there'll be a growth curve, so you can kind of follow that. I like how the it's color-coded very strongly for girls and boys on there. All right, so I'm going to talk a little bit about a few illnesses then. Any questions at this stage? No, feel free to stop. Yes?
Does the clinic card for the child,
Yep.
can it be carried with the parents?
Absolutely. It follows the child. So, and they've tried to do some sort of electronic health records as well, so to enter those data into a national database, but it's struggled. So all information that you can get on a child is really, if they were to move to areas or where they would show up at a different health clinic, all of that is taken off that card. And it'll also have vaccine schedule is on here as well, vitamin A supplementation, all that. Yeah. Yeah. Really is the lifeline of health information on kids when they show up into a hospital. Yeah. So I'm going to go through a few different things, and then we'll get to kind of the fun stuff, which is talking about a few studies that I was involved with. But malaria, it was the first one. So that's the mosquito, Anopheles mosquito. Have you guys seen that? Anybody been bitten by that? No, still scares me. And these are thin and thick smears, right, to when we look to diagnose malaria. So this is kind of an older way that we do, but looking under a microscope for the parasite on there. The thick one is that, and then there's the thin one, and you can kind of see the malaria parasite inside red blood cells. Yeah. So I wanted to show these data just a little bit, just to indicate that there's been a marked improvements in malaria treatment and subsequent deaths in kids in areas like Zambia over the last 18 years. So this is done through something called a Zambia Malaria Indicator Survey, and that's where they, again, 4,000 households were sampled on this one throughout different parts of the country, and making sure that all regions are sampled appropriately and proportionately. Well, they'll go out and ask families about malaria prevention strategies, and then they'll also test all these children out there. So you can see throughout time on this one the prevalence rates. So again, I arrived in Zambia around this time, so they were making some strides, and then something happened over the next few years, and then it's kind of going down again. And you can see that through the national. So there will be various cycles with our ability to treat malaria based on how bad the season is. So we know it's endemic there. It's throughout, mainly through the rainy season or towards the end of the rainy season, and certain parts of the country are different than others. But again, it is a tough battle with malaria, but again, it seems to be improving on this. This gives you an idea in the same surveys where it's disproportionate. So certain areas where I lived in Lusaka, we didn't see that much malaria, but it was still there all year round. But other parts in the western province, and then if you look up in the northern part of the country, the malaria prevalence was much, much higher on there. This is kind of tricky to look at, but this is one that, in the study that I'm going to talk about is going to get into this a lot. But this is kind of interesting. When you look at under 5 kids, this tells you if you look at the treatment. So these are people, and most of these are kids presenting with fever, not because fever is the #1 sign for malaria, but this to ask families, did you actually seek treatment for that? So, and you can see on this, in the areas, certainly more in urban, but in rural areas, but people are seeking treatment. Did you receive a finger prick? Meaning, did you actually get tested for malaria? And if you were tested, did the test come back positive, and then were you treated? So if you look at this, if you looked at this same graph from about 10 years ago or 12 years ago, so people equated fever with malaria, and they weren't even testing for it that often, and they were just giving kids treatment for this. And in fact, the same thing a little bit in the adult population, which has led to resistance to malaria. And again, I'll talk a little bit more about this in a couple slides, but really isn't the thing you really want to do on a public health level. You want to keep your medications working against it. Therefore, you only want to treat for that disease or that infection when there actually is evidence of that. So this is a big thing. And finger prick actually nowadays is because we're doing a little bit something called the rapid diagnostic test a little bit more on it. And these are some of the reasons why there's been some improvements in malaria. So one is, this is what we call a rapid diagnostic test. If any of you are traveling to malaria endemic regions, feel free to pick this up at the pharmacy as soon as you arrive in that country, because I actually trust that more so than when I come back to the United States and try to get diagnosed for malaria in my own hospital. But all you have to do is prick your own finger and put it onto this well, and then it'll test for the two most common types of malaria, and the most dangerous type, which is the falciparum, on it. Insecticide-treated bed nets, so people are sleeping under them a little bit more. That's made a huge difference in malaria eradication. Indoor residual spraying on the right, so spraying homes actually to kill off the parasite, the mosquitoes. And then the last one is looking at the new artemisinin and combination therapies, which is a new class of medications. Not so new. I mean, it's been out for the last 20 years at least. But the WHO has recommended 2 medications against malaria and all infections, and that's really made a difference on it. You're starting to see some resistance in Asia, but they're not seeing it yet in Africa. Yeah. Which leads me to one of my first studies that I really wanted to talk about, and that was this idea of a study called the ZimMap study. So this was one that we focused on looking at malaria and pneumonia in kids. And again, part of the reason was at the time we did this study that everyone equated fever with malaria, and therefore everyone, for the most part in health facilities, were treating it, regardless of what the results were showing on the microscopy on that. So it also was one that we wanted to really look at use of community health workers. And this is in this notion of area that I've worked called integrated community case management of childhood diseases. In places like Zambia, where you don't have that many healthcare providers and there's such limited availability, really wanted to tackle or tap into the informal healthcare sector workers to see if they could actually take care of common childhood illnesses. And community health workers are some of this workforce. Prior to our doing this study, the Zambian Ministry of Health policy was to have community health workers, and they would train them. So these are informal healthcare sector workers that still are operating at Ministry of Health type health outposts, are not garnering a salary, or getting some training, but most of the time the training is if you see something sick, send it on to the health facility, which may be hours away at times. Yeah. And again at this time, there was really no information on could you actually use community health workers to either test for malaria in these communities and also then provide the artemisinin and combination therapy to actually treat it. So that's kind of what we did. We looked at an area, we designed a study, and I'll show you the area here where we took clusters of these. So we took community health workers in one cluster and we trained them on the signs of pneumonia. So we were also looking at pneumonia. And again, remember, in childhood health, pneumonia signs, which is fast breathing or fever, may interact or overlap often with malaria signs, because kids with fevers, immediately their respiratory rates go up. So they may look very similar to it, and there may be overlap. And there's also co-infection that we would see in this. So we took clusters of community health workers in one area, and the others were our control area, where we were helping train them on danger signs in kids, but everything was referral onto the health facilities. In the eligibility criteria, where we were looking at kids presenting with fever or difficulty breathing or fast breathing within 6 months to 5 years of age. And we really didn't want really sick kids, so we wanted the community health workers to recognize significant illness, but also refer those kids that looked like they were very, very sick immediately to the health centers. Yeah. We did this in a part of southern province. It was between 2 districts and near this really beautiful hospital, Chikinkata Mission Hospital on it. As you can see, fairly rural population, 70,000, and then they had only 1 hospital in the area with 5 rural centers. Yeah. These are kind of what the study sites look like. So here's the rural health communities, and here are some of the community health workers. So fairly basic areas. But again, families, moms would take their children there to be evaluated because it was such a long distance to travel to other health facilities. And we were training the community health workers in these areas. Yeah. Okay. And these were the objectives of our study. We wanted to see if we could teach community health workers to recognize non-severe pneumonia, so not very sick pneumonia, and that's a WHO definition of that. Could they actually recognize it and treat kids with amoxicillin, which is the treatment of choice for pneumonia in most parts of the world? Can community health workers use the rapid diagnostic test to really to prevent overuse and overtreatment of malaria? And that's what the ACT stands for. And again, you can see some of these others. How well are community health workers able to classify and prescribe treatment? And can they handle the supply? So can this actually be a scalable type of activity? Okay, I don't know why that's doing that. Ah, there you go. So training. So what we did was we trained both groups. So both groups got a training surrounding identifying serious illness and how to classify malaria and pneumonia. We also did referral forms so that we could understand what was going on. So if a community health worker saw a child that was eligible for the study, they'd be enrolled, but also then referring them onto the facility and then back to the rural health communities so that we could understand what was going on. We used multiple methods to train, and people really in Zambia, the community health workers, loved being trained and learning a new skill that they felt was important to their community, for sure. And then we also did this with the district health offices as well. Yeah. So again, here's some of the differences. So the intervention, we trained them to perform rapid diagnostic tests for malaria and how to interpret those. And we also gave them a supply chain of amoxicillin to prescribe if there was evidence of pneumonia in these kids. And again, remember, in these ages, that's just a history of cough or difficulty breathing and a certain respiratory rate. So it was easy to, we provided timers as well, thermometers as well, to both groups so that they could see this. And then you can see what we trained both groups at. These were algorithms, and they're kind of busy, but this is kind of told people to go down one route. If this child had a fever, if the rapid diagnostic test was negative, if the respiratory rate was this is what you treat. And oftentimes there was no treatment. So as you guys know, many of these were viral illnesses, so that the algorithms only suggested making sure the kids were well hydrated, or the kids were receiving antipyretics, something like Tylenol or Motrin for fever. Yeah, on it. So when we looked at these, we clustered these around the community health worker, because you can't ask a community health worker to treat one kid one way and then the next day treat them another. So the clusters were either trained, all the kids that were seen by the trained ones, or the ones were in the intervention arm, and then the other arm was the control arm. And this gives you an idea of who this population is. So we had about 40 community health workers that we trained. They were on average 40 years old. They had education, but they really weren't doing this full time. So that was a little bit of a discrepancy that we were not anticipating between the control arm and the intervention arm. But the control arm had about a quarter of them actually were doing this job full time. And again, this meant that the community were paying them in either money or kind, because the Ministry of Health were not paying these health workers. Yeah. They had some experience on it, and then they were also often in areas. The informal healthcare sector workers and traditional birthing attendants are another one of these. They are actually incorporated with the rural health communities and for trainings and teachings and outreach stuff. So again, it's a mixed model, but it seems to work really well in Zambia. And this gives you an idea of the participants in it. So we overall oversampled in the control 2-to-1, but 3,000 kids, so this is a large study, right? So 3,000 kids treated at these areas. They were young, they were about 22 months old, as you can see. There was a lot of malnutrition in this area, so these were at baseline fairly sick kids, and then this gives you some ideas of the mother's population. And again, so in something like this, we'll look at what relative risk is on these, but here's what it looks like. So if you looked at kids treated with malaria medications, the ACT. So in the control groups, 99% of those kids were still presenting with fever. All of them were getting anti-malarial medications prescribed to them. In the intervention, though, that dropped down to 27%. And that was one of the main goals in the study was, could we actually prevent overtreatment of malaria in this community just by training people to use rapid diagnostic tests? And the other one also was the early and appropriate treatment for pneumonia. So we know that if you treat pneumonia earlier, it leads to improved outcomes, and that's within the first 24 or 48 hours of symptoms. So if a community health worker is being trained or taught to refer that person on and they can't get there for 1 or 2 days, they're not getting the appropriate treatment at an early enough stage. But in the places where, in our intervention arm, you can see that they were getting 87, almost 90% of these kids actually received amoxicillin at the appropriate dose and early enough. And then, and again, that's what that second one statistic looks like as well. Yeah. So really, what this also, and the Ministry of Health was really watching this, so we really showed that you could actually train informal healthcare sector workers on how to interpret rapid diagnostic tests and also to help treat for pneumonia. And since then, and this study was done around 2009 and 2010, this study has been adopted as practice by the entire Ministry of Health in Zambia. So we did not look at any deaths in this. It was going to have to be too large of a study to see if it had any improved mortality. But given that these two illnesses are two of the leading causes of death in Zambia amongst kids, we hope that this has improved some child survival. So anyways. How much time do I have? Oh, I still have a little bit of time. So the next one I wanted to tell you or talk a little bit about was the LUNESP study. So this was the Lufanyama Neonatal Survival Project. So this was done in an entirely different area of the country, but again, was involving informal healthcare sector workers to try to improve some sort of child survival. And this one looked at neonatal, it looked at kids right around the time of birth. So again, as you remember a slide I presented earlier, the most common causes, neonatal sepsis, birth asphyxia, really are two of the top causes of death within the first week of life, or first minutes of life actually. Sorry, not neonatal sepsis, but the birth asphyxia, as well as hypothermia. So hypothermia leads towards poor outcomes. It's not necessarily a cause of death, but it can lead towards poor outcomes as well. So what we wanted to do on this one was take an area where an area of Zambia where many of the deliveries were provided by traditional birthing attendants. So that's what the TBA stands for. So many studies have looked at trying to improve TBA's safe delivery because traditional birthing attendants deliver a lot of babies around the world. Unfortunately, there hasn't been a study that has shown that that's improved moms' outcomes, but we wanted to focus on actually improving babies' outcomes. Some of the reasons why that there hasn't been a study that has shown TBAs have improved mom outcomes probably has more to do with how to design a study like that. So when you're talking about an event that occurs in terms of 100,000 live births, it's really a large study that you have to do to actually show that there's some improvement in outcome on that. And it takes a long time to do that. But again, some of that also may be due to the fact that when bad things happen around childbirth, they're unpredictable, right? And so there needs to be immediate availability of emergency surgical care for a hemorrhaging mom. So C-sections, right, when things aren't progressing, or blood products being available. And many of these things we can't predict. So that may be why TBA studies that have involved TBAs that have occurred out in the community may not have shown any impact around mom survival. But we wanted to focus on these TBAs and child survival. So as you can see in Lufanyama, 30 to 40% of deliveries are actually occurring by trained TBAs in the community. And then you can see 20 to 30% still were being, at the time of this study, were being performed by at homes, but by not even TBAs. So that's a large proportion of women that are giving birth in rural areas in this district. Yeah. So we thought that maybe they would be ideally suited to actually take a look at child survival. This gives an idea of what that means to live in Lufanyama and try to deliver in a health facility that actually was able to. And you can see this. So really most women live greater than 1 hour's walk to a health facility, right? And a large proportion of them lived 2 to 3 and greater than 3 hours. And so again, when a mom goes into labor and then has to be transported or has to walk to health facilities, they're really not going to get there in time to actually safely deliver in a health facility. That wasn't the case with our traditional birthing attendants, who actually are more community-based. So that's why we thought that this may be a reasonable thing to study. So again, and it's also, we thought that it may be a thing that we could generalize to other parts of both Zambia, but other places around sub-Saharan Africa, because Lufanyama was very typical of a setting, right? It was rural, it had high rates of neonatal mortality, and had high utilization of traditional birthing attendants on that. Again, small population in a big area on there. 12 formal health sectors in this large area, but no hospitals. Yeah. So what we did on this one was a little bit different. We wanted to design something that was simple, that was acceptable to the community, that was low cost and broadly applicable, and something that we could scale up on this. So what we focused on in this study was training an intervention group or traditional birthing attendants a modified version of the neonatal resuscitation protocol. So NRP is something that we train providers in the United States for, but really involves, around birth, stimulating a baby who may not be breathing well, or providing some sort of blow-by respiratory effort, and not even needing oxygen. We've actually shown that oxygen can be more damaging than good, but just stimulating a child to breathe, swaddling a child, drying a child off, and really, in our NRP in the United States, eventually we'll get towards mechanical ventilation and use of medications, but again, in a modified one in these settings, we didn't train that at all. We just focused on some of the fairly basic things that can occur around childbirth. And we also wanted to focus on early delivery of antibiotics if there was any evidence of infection, and referral of those kids on immediately to a health center on it. This is something called kangaroo care. I don't know if you guys have seen or heard this before, but this is for warming babies with mom's own body warmth after delivery, after you dry a baby off, immediately attaching her to her chest. And we taught some of this for the hypothermia stuff in this study. Yeah. Okay. So our primary objectives on this one was to see if we could train traditional birthing attendants to identify and manage birth asphyxia, to prevent postpartum hypothermia, which leads to poor outcomes, as I mentioned earlier, and then again to see if they could be trained to identify signs of infection and give first dose of antibiotics. We did this, and I didn't want to spend too much time, but again in a cluster randomized trial. So again, if you've got a traditional birth TBA working in one area, you cannot expect her to do one thing one day and one thing the next. Although there have been studies that have looked at it that way. But again, it's so much easier to think of this as clustering it around the traditional birthing attendants themselves. Right. And again, as I mentioned, we did a modified NRP on this. We taught how to identify early signs of sepsis. We equipped the TBAs with bulb suctions, just to suction out noses and mouths on it, as well as that thing called the Layerdal resuscitation mask on this side. So again, and I'll show a demonstration, you can see it there, where literally if a child's not showing any sort of respiratory effort after stimulating and suctioning, they can start actually giving breast through the Layerdal mask, and pretty easy to use. And as I mentioned before, you don't need to give oxygen. It's the stimulation actually that causes these kids to start breathing again. It's not necessarily oxygen that they need, on it. And in the control areas, again, we helped train them on just the standard of care that was used for safe delivery in Zambia for TBA. So this was the Ministry of Health type program, but we retrained them during this period. These were all of our TBAs, these were some of our TBAs and some of our data collectors. So we put data collectors out in the community that work closely with the TBAs to take a look at the data. And this gives you a little bit of idea who our TBAs were. So when our community health workers in Zambia are mainly men, these are predominantly, in fact, almost all, I think all of these were women. There are a few male TBAs in there. Not a ton of formal education on it. You can see the distances to the health facilities, and then you can get an idea of how many deliveries they were. And this study lasted a little over a year. So these women are delivering often, but not on a daily basis. Yeah. And this gives you an idea of mom on it. And again, the ends above it are the number of kids. So we looked at about 3,500 kids during the time of this period, which is a very, very large study on there. Most married, large number of families. Lots of visits to the antenatal clinic, which is a great thing, right? So women are taking on average 3 visits. And again, when you look at some of the preventative things we do in Zambia to improve mom's health, we'll treat presumptively for malaria so as to prevent some anemia in these women. We'll check for HIV on all these visits. We will also give tetanus boosters to prevent tetanus in deliveries. Yeah. And this gives an idea of the conditions of the kids. So again, around 2,800 births were done. Most of these kids, sorry, a little bit more than that. The total numbers are below. So what was it? Around a little over 3,000. Most of these kids are doing fine when you look at their breathing as recorded by the TBAs. We did not oversee any of these deliveries as a research team. Our data collectors were out in the field, but again, we taught the TBAs how to collect some of their own data. And you can see a proportion of kids coming out not breathing at all. And this again, and I'll show you this a little bit better in percentage, but we also talk about the risk. But again, our main outcome was looking at death at 28 days. So we did all these interventions, but we really wanted to look at one outcome, was did it save lives? Did it help kids get to 28 days? And this is where you'll see that again, this is a combined, where is it on here? Stillbirths early. Here it is. So if you look at the intervention area, the death rate was around 24.5 per 1,000 live births. And then in the control group, that was at 40. And again, when I kind of crudely to understand a relative risk, that means if the relative risk is less than 1, it means that that's an improvement in survival. And if the intervals around that do not cross 1, it means that that's significant on there. So this was really a big study that got a lot of attention because we were looking at a very hard outcome, which was a 28-day survival of kids. We included stillbirths in there, which is kind of more interesting because we didn't want traditional birthing attendants to misclassify a child that came out not alive as a stillbirth. It's hard to tell the difference. So we included that in this one just to make sure that the differences in stillbirth rate wasn't actually making up for that survival benefit. Yeah. And then if you look at a couple of the interventions, this was the breathing one. So in the again, not surprising because we didn't provide pocket resuscitators, the Layerdal masks, but a large proportion of these kids were actually stimulated with breaths through the Layerdal mask, which we could not tease out from the study which part of this caused the greater improvement. But if you look at the timing to death, the likelihood is that most of this was the modified NRP, and really none of it may have been associated with the identification of neonatal sepsis. And this gives you an idea of how many kids were actually given a dose of amoxicillin and then referred. Amoxicillin is often used in these settings because it's safe, because it's available, because it doesn't degrade in heat, so you can actually keep this. You don't need to refrigerate it. And because of the organisms that often we'll see in these kids, it'll look at the gram-positive organisms, which a lot of these kids will have in the neonatal period. So some of the conclusions we got from this were that the TBAs could actually be used in saving neonatal lives on this one, that we don't know exactly what caused the reduction, but we think the combination did. So we've expanded this in the years since this study was done, and this is being used in also different parts of Zambia. Yeah. I'm going to I've gotten through 2 of these. I'm actually probably going to slow down and stop at this stage because are we concluding in 10 minutes, Peter? Yeah. My last one, I wanted to talk a little bit about pediatric HIV and something, but again, I'll have to be invited back. I don't want to keep you guys here too long. Yeah. Sometimes. But this was taking a look, this one was looking, I was going to give some information on pediatric HIV and some of the stuff that we did around early infant diagnosis of HIV. Sorry. Thanks. There was a concluding slide on here somewhere. Sorry, that was like all this buildup and very little delivery on that one. But again, some of the conclusions I would say on this is there's been some improvement in under 5 child health, but there still is some improvements that we need to continue to make. And again, looking at some of the community case management literature out there, if you look at areas like Pakistan with the Lady Health Workers Network, which is an amazing part of their Ministry of Health now, and the improvements that they've done with child survival, that there may be some solutions in areas like Zambia and Sub-Saharan Africa that involve the integration of informal healthcare sector workers towards goals of improving childhood survival. And again, these are some of the studies that we've been involved with, and my group is involved with in areas like Zambia, and we continue to do that. So gains have been made, but there's still some that need to be, in particular, focusing on the neonatal period. And again, we hope to see that these child survival improvements continue. Yeah? So thanks. Yeah.
Great. We have lots of time for questions. And so who would like to start?
How long is the training, like for the malaria?
Yeah. Yeah, great study. So for the TBA training in particular, we did 2 weeks. So we did one very intensive week that we just reviewed safe delivery practices and some of the things. And then in the intervention, we did an additional week. At that end of the week, so we used a lot of mixed methods. We took like the small baby. We did all sorts of practical stuff. We did videos, and then they actually had to pass some sort of one-on-one practical exam so that we could see that they were learning the modified NRP. So we invested a lot of time in the training, and then we would do refresher trainings that we actually had members of the district health management team, not the research team, come and give those on a 3 to 4 month basis. So some of the questions that this may be referring to is not only how intensive is the training, and again, a week doesn't seem like a long training to me with interval ones every 3 to 4 weeks, but some of the literature is trying to look at how well do these skills actually get retained by any healthcare worker, let alone informal healthcare workers, and we don't know that from this study. We would have to look at that a little bit longer term. Yeah, but fun trainings, intense. There was actually a ceremony when we actually did the random sampling for the TBAs that the community really wanted, and to see if they got an intervention versus the control group. And with the community health workers, it was probably a little less than that. It was 4 to 5 days on that training, with, again, refresher trainings every 3 to 4 months. Yeah.
With the TBAs and that study, did you have a chance to collect any qualitative type data, or did you get an impression of what they found to be most useful, or what was?
Absolutely. Absolutely, great question. In both these studies, we've done qualitative. It's always great to ask qualitative questions to see acceptance. Did it change health-seeking behavior of your community on there? But on this one, absolutely we did, and the TBAs loved it. They loved the layer doll. They loved the simple things like the swaddling, the ability to stimulate. And again, I used to see this a little bit as well in the main hospital, that a non-breathing baby in Zambia was thought to be a dead baby. And again, we know that that's just not the case, right? So kids sometimes, their babies just need to be stimulated a little bit, and then providing some respirations with them. So the TBAs thought that that was a great skill to learn. They wanted to learn more and more of it. They felt that this really made a difference in their standing in both their community, but also in terms of the service that they were providing babies. Yeah. They kept asking, actually, in some of the qualitative reviews, could we do the same for teaching safer delivery practices? And again, that was not the focus. Our group was really focused a little bit more on child survival than mom survival. Yeah. Yeah.
From your experience, do you think that you can have more impact with technology or person-to-person, like the community health worker? Not that you want to avoid either one.
Sure,
Where do you
sure.
start and where do you go?
Well, that's a great question because, again, I was involved in some studies that involved technology and improvements, in particular the one I was going to present there on early infant diagnosis and the use of SMS technology to get HIV results back to facilities. I think in the long run I'm a humanist more than anything, so I think one of the reasons why many of us got into the health profession was to deal with people. And I think that in areas like Zambia, where really both the government, at the government level, but also at the community level, they've really developed a cadre of healthcare provider because of the needs of the community, much more so than any sort of kind of calling a profession. So these community health workers and TBAs were working in settings where they weren't getting remunerated by anyone at the Ministry of Health, and yet the ministry was asking some things of them around trainings and things like that. So I really like the human aspect of this. I think that when it comes to training, and particularly if some of the skill set is sustainable over time, where I think that we can do a lot of good improvements in healthcare delivery. Yeah. Did that maybe that I don't know if that answered that completely.
No, I think
Yeah.
it does. I guess the follow-up question then is what happens if you pay or you can get back? Because I mean, some of those people were 98% of the time they weren't.
Yeah, no, absolutely. Yeah, again, great question. I don't know if I know the answer of that. I do know, though, that when we came back so we went back to the Lufanyama area and tried to do a pairing study. And actually, this was after I had left Zambia. And this is the guy there was a really wonderful Ghanaian researcher that worked with our group. And he was really the designer of the ZimMap study that looked at the malaria and pneumonia. He took that, and they took LUNESP. And Save the Children actually wanted us to design a program that combined those two skill sets and made that TBA with a community health worker work as a dyad in these communities and really look at both child survival as an endpoint as well as neonatal survival. And so, I think that, I don't know if I'm too cynical enough to know that if it's starting to pay these actually may diminish efforts and or results. I don't know the answer to that. Yeah, to be honest. Yeah, that's a tough question. Yeah.
So I'm really impressed with your work because I like your focus on informal healthcare providers. You didn't really quite put together the setting for this, though. I think the setting is the shortage of professional healthcare providers, not just in Zambia or in Africa, but around the world.
Sure.
So my first part of my question is, can you tell us a little bit about that in Zambia? I mean, where are all the trained professional healthcare workers going? And then the second part of my question is, we were just talking in my class today about the fact that we've got this booming aging population, and we're talking about long-term care. So it seems to me like one of the best ways to deal with in-home long-term care in this country is through informal healthcare providers. So did you learn any lessons in Zambia that we could take back and use here?
Yeah. The first question, Peter, so yes, I probably should have framed this a little bit better around the healthcare provider shortage around the world, but also in Zambia. So Zambia in particular, I mentioned some of those physician statistics, but if you look down at nursing statistics, clinical officer, which is another cadre of worker, literally everyone in Zambia that's being trained is trying to find a different place outside of Zambia where they can actually earn a living with their profession. So that is called the brain drain, and this has been going on forever. And in fact, a country like Zambia has tried to create a type of healthcare professional that does not equate in an outside country in efforts to actually retain healthcare workers within Zambia. But physicians there were immediately going off to research jobs with organizations like Boston University, whom I was working for, or were Ministry of Health positions, or running district hospitals, but not actually providing health care for Zambia. So this is a huge, huge problem around the world. And again, it's a problem that we see also in the United States, where we don't have enough healthcare providers for our population, particularly if you look at variations in urban and rural populations that you all know in the state of Montana, and which I know very much in the state of New Mexico. So yes, that probably sets the picture a little bit better around the healthcare worker shortage in a place like Zambia. Your second question, one is, so has it, I guess, imparted to me information or knowledge that I may then take back towards use of informal healthcare sector workers in the United States. So Peter's mentioned something that, again, that we see a little bit more of, although is people that do this in end of life, whether it's on a formal basis or an informal basis. We have employed in the state of New Mexico a lot of community health workers that are attached from patients that come into the emergency department that are discharged, that are then followed up into the community by volunteer healthcare workers. And again, in a rural state like ours, in a state where we don't have much healthcare provision, particularly outside of Albuquerque, I think that there are some lessons that can be had from this. But again, I'm a little bit insulated in an emergency department in Albuquerque versus is really working on the frontiers of areas in my state. Yeah.
Just one quick follow-up question.
Yeah.
And that is, you talked about brain drain, or sometimes it's called the fatal flow of expertise. What about the return of talent? What about brain circulation, which is a big thing these days? Are people contributing, coming back, either virtually or online? Are they contributing in some ways? Are you seeing that circulation of expertise going back to Zambia at all? Any evidence of that?
Again, a great question. I mean, I think I'm unfortunately a little bit far outside the loop, where I'm doing a lot of armchair research design and going to Zambia once or twice, once a year, once every 3 years to really see it. I do know that a lot of the resident physicians that I trained in Zambia that are all in these pictures, they are either, I've seen some of them come back, but I don't know the actual statistics on that at all, Peter. I do know that, again, we've got something in New Mexico called Project Echo. Have you guys heard at all about Project? It is a kind of telementoring program that was designed really in the rural state of New Mexico by a GI doc, actually, that looked at hepatitis C treatment in rural areas of New Mexico, and whether we could do telehealth mentoring, not telemedicine. So these weren't necessarily patients coming in front of the screen. They actually were providers that were taking care of hepatitis C to see if their outcomes could improve in rural areas. This has taken off all over around the world now with this Project Echo as a platform to actually provide the telementoring. And again, I've seen people like me then get involved back with this to help, even in the United States, help train providers in areas like Zambia of some of the things that I know from working in those settings. So, yeah. But I don't know exactly the numbers on that. Yeah. Yeah.
So I got a couple of questions. First of all, on the map of Zambia, before you said that the rates of malaria were a lot higher in the north. Is that due to climate differences, or because I don't know?
Yeah, my apologies. If you look at most malaria endemic countries, you will see much regional variation, and some of that will do with that. Yeah. So yes, you will see that in many countries. In fact, I was just looking at this in areas where I'm working right now in Kenya to see what the country variation is. Some of that will have to do with how bad the rainy season is, and some of that will have to do with where there's standing water for these areas, and some of that has to do with elevation. So we know Zambia, and some of the things I didn't get into, Lusaka sat at 4,000 feet, and in fact it was on the end of the plateau going down the Great Rift Valleys. So in higher elevations, we won't see nearly as much malaria based on mosquito population. So yes, there is variation. That's yearly variation as well. There'll be typically a malaria season, but this is not uncommon, and that's due to many of those factors. Yeah.
I was a little bit curious how you could have such low rates, prevalence, and then right next to sort of whatever regions or states with such high prevalence.
One is these. Yeah, so some of that has to do, again, remember the malaria has to be around. So when you have very rural populations, and this is when people go visit like game parks and stuff, and they always worry, am I going to get malaria or not? When you don't have a human population, you're not going to have malaria. So as it gets more rural, you'll actually see that'll go down. You need a people population. But also remember that that's the size of a little bit larger than Texas. So that's a big area. So as much as they may be next to each other, it's a fairly large area represented. I am not a malaria expert, right? So apologies if I'm wrong on some of these answers.
And then my other question is that you seem to like have moved your whole life there for a while and then decided to come back.
Yeah.
How is the adjustment for yourself, for your family, for your kids? Do you think that it's sustainable and overall beneficial?
Yeah, wow. You put me on the couch for that one, and I'll tell you all that. So one is I came back about 6 years ago. So the adjustment for the parents was always tougher than the adjustment for the kids. The kids seem to be a lot easier at that. But my wife and I struggle with this all the time. So I loved what I did in Zambia. Absolutely loved it. I love the fact that I continue on with research there. But there were things of it that were also difficult. And for me, professionally, living from grant to grant and all that, all the angst that came with that really got to me for a bit. And also the fact that I was kind of practicing medicine in an area, I was practicing a profession there that I wasn't in the United States. So being an ER doctor in the United States is very different than running an ICU in a place of Zambia, and I kind of missed some of that as well. So we will be back there. Those pictures of my kids were very many years ago, so our youngest is now 16, and as soon as he's out of the house, my wife and I will be on a research study somewhere in Africa for a few years, but we struggle with this. We totally struggle with it. She's not at all. So she is a project manager, mainly worked for IT companies. So when she was in Zambia, she worked for the largest satellite internet company. And in fact, her job was pretty inspiring with young professionals in Zambia on the private side. But she now works for this Project Echo that I was talking about on the project management side. And they're really expanding back into areas of Africa. As much as I like thinking of child health and community case management, I really, really like thinking of it in areas like Zambia. So I think that we will be back there at some stage, at least temporarily, working on a research project. My work right now, I get asked to help design studies and proposals a lot. And now I'm really working with a group in Western Kenya that's looking at childhood illnesses again. Now this is with real scientists. I'm an epidemiologist a little bit, and I like thinking through innovative solutions to complex problems. But one of the researchers at my institute right now basically looks at the genetics of immune responses. So why in these two kids in Western Africa does one get a more severe case of malaria than the other? And part of that is the immune response to the illness. And he looks at the genetic codes of that. So I have become their clinical epidemiologist that's helping them with this, and I'm training their providers on algorithms to hopefully help improve outcomes of the kids where they're actually doing these studies and kind of looking at their data. So we will be back somewhere in this area at some stage. Hopefully, we'll see. Yeah.
Health reductions in under 5 mortality have any immediate effects on the health of the rest of the population, or is it more of a long-term strategy?
Yeah, great question. Again, when the more dangerous, if the goal is to have a larger, improved life expectancy, then yes, that it does, because once you survive that kind of more dangerous period of life, then one can go on to be educated and do all the other things. So if that is the goal and looking at improved life expectancies in a place like Zambia, then yes. I would answer that yes. Yeah.
It seems like they've got a really proactive, like, policy making system that they work with people coming in, or like they work so closely with you in your research.
Yeah.
Do they have they like preemptively gotten ahead of this sort of inevitable growth of population should they implement all of these different tactics that you have proposed?
Yeah, I mean, again, great, bigger picture questions. Like, so is there? I guess the question is there a size of Zambia that becomes unsustainable for the country? And again, that's a tough question to answer.
Or like, is there active government prep through policy for that inevitable increase in population?
I do not know the answer to that. I really don't. I do know, though, that, again, it's interesting because, if you look at, in particular, Southern Africa, that there are a lot of institutes that have kind of aligned themselves with certain areas of Africa. So like Boston University was active in Zambia. And the U.S. government under our PEPFAR, so are you guys familiar with PEPFAR? So the President's Emergency Relief for HIV or AIDS in Africa, that was probably the only thing George W. may be remembered for positively, is a large amount of money that goes to support HIV care in places like Zambia that have high HIV prevalence. What it's done is created some sort of codependency on ministries of health for these places that really cannot fund the activities that are being implemented in their own country. So this, these are bigger, totally ethical type questions that really, need to be addressed, both at the Zambia level, but also at the institute level, and whether these are appropriate things to go on. Yeah. Sorry, I'm evading that question as much as possible because I think that it's a tough one to ask. I mean, certainly I don't look. I say this. This is interesting. Mainly so I integrated myself as well as I could in Zambia. I gave my time to provide health and was asked to at the ICU. But in the end of the day, after 6 years, there is no doubt that I was always an outsider in Zambia. So I don't feel presumptuous enough to really be able to answer the question for Zambia if these are good long-term goals or not. I think in general, helping children to survive to the age of 5 is a great goal. I really do. And so that I feel comfortable doing. But if this leads towards larger problems for a country like Zambia, I don't think I'm the right person to answer that. Yeah.
I think there's pretty overwhelming evidence that kids in Africa who make it to age 5 have a robust future ahead of them. There's much even a very long-term lifespan for, if you just look at those kids who make it to 5, the lifespan goes up considerably.
I mean, it's interesting in the larger picture of these. If you look at a country like Zambia, as soon as you start seeing people survive, and then as soon as you start seeing people, in particular women, get educated, and as soon as education leads towards greater opportunities for earning money, leads to lesser deliveries of babies, leads to increased birth spacing, which it also we know leads to greater chances of survival. That actually, if you look at overall under 5 mortality, is probably more important than any study that I've done on this. It involves education, in particular education of women. This has been shown time and time again in a place like Zambia. So again, I'm not saying that we shouldn't be immunizing kids there. I just think that if you look at many of these indicators, they're so intertwined with education and wealth, or the access to actually being able to feed your family and kind of survive a poverty cycle, that, again, too presumptuous for me to think that some of the things that I'm doing is actually driving under 5 survival. Yeah.
So I think it is a great question, though, because when you have significant interventions, like when the WHO went in and vaccinated kids in the 60s and 70s, all of a sudden population expands, and if agricultural practices don't keep up with the ability to provide food for those people, then you've created almost as many problems as you have solved.
Which is a great segue to the talk that Chris Ziegler is going to be giving in this lecture series a couple of weeks from now, right? So that's great. That's really a beautiful segue to that. I think we have time for one more question.
Yeah, the amount of formal education of your study participants was pretty low. It was under 50%. So how are you able to win over the population to participate?
I think one is we were working for both these two studies, working fairly rural populations. And so, again, very inviting communities in terms of with the thought that at least some of their providers were going to be trained on new sort of skill sets and new ability to take care of either childhood or neonatal illnesses really went a long way. We also, look, we weren't just Boston University coming in. Most of our employees were local, and so we were invested in these areas. We got, we kind of went from both the bottom up as well as the top down to try to make sure that this is exactly what the community, if it was going to be, the community wanted this, and well as the district health committees and the like. So, we really worked at this, and again, these communities really were appreciative of any sort of skill set that were being provided or taught to their cadre of healthcare providers. Yeah.
Well, before I conclude on today's talk, I want to mention what's coming up next week. So next week, Donna Bainbridge, who is an adjunct professor here and also a clinical advisor to Special Olympics Global, is going to be talking about inclusive and equitable health and wellness for persons with intellectual disability, how Special Olympics fosters systems change. So that should be very interesting. So I just want to say that this lecture series really focuses on the contributions that people are making in terms of global health, and I think that it really was well illustrated tonight by the kinds of dedication that Phil has contributed throughout the last several years of his life and continues to contribute in Zambia and Kenya in really very important ways. And so we owe him a debt of gratitude on two counts tonight. One, because he came all the way from New Mexico to talk to us about this, but secondly, because of all of the effort and dedication that he's made to global health in Africa. So thanks very much.